There is an important shift in the way that health research is being conducted, whereby patients, families, and the public are being involved as partners as much and as meaningfully as possible. What is the added value of patient engagement in research, and what are some of the barriers and facilitators to patient-oriented research? This is episode 28 of PEP Talks, the Patient Engagement Podcast. In this episode, recorded in the summer of 2020, we speak with Frank Gavin, who is the chair for the Public Advisory Council at Health Data Research Network Canada and is the former director of citizen engagement for the National Child Right Network, to name a few of his many roles in healthcare and health research. Frank shares his wealth of knowledge and insights in patient engagement in health research. Paul Ferry first asked Frank to tell us a little bit about himself.
Yes, I'm a retired community college English teacher, and I live in Toronto with my wife and our young adult son.
So how did you first get involved in this world of patient engagement?
Well, I think I'm a long timer, I guess you could say, or even an old timer, because I got started, I guess, in 1995, when I don't think the term patient engagement was even being used.
Probably not.
I got involved at Sick Kids in Toronto. My son was a patient there, and at the time there was a family advisory committee, and our focus then was on what was then called family-centered care. Later, sort of patient-centered care we were conscious of the fact that even at Children's Hospital, care should be not only family-centered, of course, but patient-centered. So I got involved in 1995.
Do you remember some of the first things you got involved with?
Sure. I think the thing was that what struck me at the time was that how opaque the world, the hospital world was. I had really was the first time I had spent any time in a hospital, and lots of the things that became more familiar over time, at least initially, were just confusing. I mean, I couldn't even find my way to the washroom from emergency. I didn't know, for example, that you could unplug an IV machine. So I was doing something, in fact, quite dangerous with my then 7-year-old son, because I think the staff assumed that something that should not have been assumed. And there were all kinds of other things as well. I think that the reasons for doing things, the nature of rounds. Rounds at that time really, although we were staying in our son's room, the rounds were entirely for the hospital staff and the students. Families, you may have been physically present, but you might have been part of the wallpaper. So at the time, I thought there was obviously a need for some kind of improvement. And so I was involved in all kinds of things at the time, looking at new models of care, better discharge summaries, the inclusion of families in care planning. There are a whole gamut of issues over time.
So based on your own experience and just things you've observed, what do you see as the proper role for patients and families in health research and quality improvement projects?
Well, I think, sometimes it's actually quite difficult to distinguish between quality improvement projects and research. That's one thing that we actually need to, I think, do a little bit better on clarifying what that distinction is. So, for example, was involved in a project to facilitate the participation of families in anesthesia induction, even to allow their presence at anesthesia induction for children. There was actually some research involved with that, at least some literature review and so forth. But it was essentially a quality improvement project, and I think getting the staff to see this as a quality improvement project and not simply a sort of patient relations gimmick sometimes. That was very important to make that distinction. But in terms of patient-oriented research, and again, when I first got involved, I guess you could say about 12 or 13 years ago, that term wasn't used much. Someone just said, how would you be interested in helping us with some research? And then the project was about family. It was called Family Matters, and it was all about the experience of families of children with neurodevelopmental conditions. But anyway, I think that the thing is that we can say about families and patients is that there are many things that they are best at contributing, that they can contribute best from their own experience. And there are other things that they alone can contribute. And I can think of a whole range of things, just knowing, what the actual experience is from the inside. There are all kinds of assumptions that are made in research. Certain measures are used, for example. They're measures that have been used for a long time. They've been validated. I can think of, for example, the 6-minute walk test for patients who have motor difficulties, patients with multiple sclerosis, for example. And yet, in my experience, talking to a lot of those patients, what actually matters to them is their ability to climb stairs, much more than their ability to walk a particular distance over a particular time. But there's a less available. I'm not even sure there is a validated measure for climbing stairs.
Yeah.
But that's the kind of thing which, if you talk to patients, you realize that, sometimes the things that are being measured are not the things that are most important to them, And so on the Parenting Matters project, for example, the family is very focused on the importance of hope. What provides hope? And of course, when you think about hope, that's connected to resilience. That's connected to, to your ability and willingness to try different things, to risk certain things, perhaps, to keep going, in short. And yet, what we were told was, well, hope is a very difficult thing to measure, and I'm sure that's true, but that's not a reason not to try to measure it.
In terms of some of the things you've seen about involving and engaging patients and families, what do you think is going right? What do you think we can improve?
Well, going right, I think I see more and more evidence of a willingness to adapt as we go along, to learn from our experience. So in the SPORE network, the Strategy for Patient-Oriented Research network that I'm part of now, Child Bright, we developed some compensation guidelines. And of course, compensation is a topic that's much discussed, sometimes with trepidation. I call it the sort of third rail of patient-oriented research. But there are all kinds of situations that we hadn't anticipated that come up, and we're learning to anticipate those a little bit better and to respond to them. We're also learning, I think, about the importance of doing much better at engaging people at the front end. It's said that patient-oriented research should involve patients and families at all stages of the research process. But I think the truth of the matter is that in many, many instances, they've been brought in after certain basic decisions have been made. And then I think we're learning a little bit about how to do some reverse engineering, how to, even if they've been brought in after the project has gotten started, to make sure that there's some opportunity to go back and question some of the decisions that were made earlier on. The choice of a primary outcome, for example, or something about who should be included or excluded in the study. So I think we're doing better. We're learning from that experience as we go.
Yes. So one of the things that we do at the Alberta SPORE Patient Engagement Platform is give advice to researchers at various points in their research cycle. Do you have any thoughts about how to make sure, or how to help researchers always include patients at the beginning stages of the research?
Well, I mean, there are some really basic things that we know are important. One of them is, you know, in the past, sometimes there would be, you know, the single patient. You know, we've got a patient involved. Now, that doesn't usually happen with a very big project, but sometimes with a small project, somebody said, you know, and it is hard sometimes. For example, we have a project in our network about prenatal oxygen therapy, where women who are pregnant and where there's some indication that the child is at risk for a problem at birth and after birth, are asked to take over time, over many weeks, supplemental oxygen. And that's, of course, very difficult. And the point of it is there's not a population of people walking around thinking, you know, and who are not yet pregnant or who are or in the very earliest stages of pregnancy saying, I'd like to be involved in a project, you know, in the event that I, you know, have this problem. So I guess what I'm saying is, you know, I think sometimes it's easier than at other times to get patients involved, depending on the nature of the project, early on. But in most cases, you know, I think people can avoid having the single patient. I think you really should, and I think it's a little bit, I think even if you have what you think is a sufficient number, it's really important to look around the table at the people who are gathered and to say, okay, what is the patient population here? And are there people with a particular kind of experience or from a particular background who are not here? Who we don't have, who nobody here has a connection to this population of patients. And then to go out, you know, and it would vary from project to project to figure out what's the strategy to make sure these patients are involved. Sometimes it might be that, you know, they're not involved at the beginning. So it's when you bring people on, how can you help? How can you, in a genuine way, help them to cover the ground already covered and to get their input on perhaps some decisions already made? You know, this can't be tokenistic. I mean, everyone knows this. This is the thing that people are very alert to. You know, the appearance of tokenism or the reality of tokenism. But those are some things. I also think some thinking about who it is who's recruiting some of the people to come on board. So, you know, depending on the project, maybe say social workers who work in a particular clinical program might be the best people to connect with and encourage various people to get involved in the research project. It might be, you know, the clinic nurse manager. You know, there could be all kinds of people who maybe traditionally have not been involved in the recruiting of such people early on, but I think it's something that we planned and reflected upon, and, you know, built upon as we learn from experience.
Yes. So thinking about issues of tokenism, then sometimes we hear discussions about the intersection between the world of patient engagement and the world of community engagement. Do you have any thoughts about how these concepts can support each other, or how they intersect, or how they're different?
Well, I think that the present COVID crisis is highlighting the need to engage not just individual patients, but communities, or what we might also call publics. Sometimes people talk about, you know, in the UK, there's very often a reference to public involvement, I mean, different terms. But I think, you know, the reality of it is, and we know this, we have different publics in terms of, you know, geographical terms, or, you know, in terms of their socioeconomic status and so forth. So there is that. I also think, you know, there is something whereby, and I think this is a difficulty that I've been aware of for a long time, that when we have been talking about patient engagement, we are assuming that, you know, people that's their identity. They're thinking of people who identify as patients. And and they're going to look at things through a patient lens. And I think the reality of it is that even people living with serious chronic conditions are, of course, have identities other than being patients.
Mm-hmm.
So, they live in a family, they're neighbors, they live in communities and so forth. And that they're, and that this represents, this is an important thing to recognize, because we have priorities and we have to think about sometimes competing priorities. So, and I think, another area that we're looking at is, especially we can see this in the COVID crisis, that, we have, if we're looking simply at health matters in a narrow context, we're missing a lot.
Mm.
There's a saying that, in fact, all policy is health policy. Transportation policy,
Mm-hmm.
housing policy, food policy, environmental policy. All these areas have a real bearing on the health of individuals and the health of communities. So I think that's something that's been to some extent missing. It was kind of a bit of a lost opportunity, I think, when CIHR named this initiative the Strategy for Patient-Oriented Research.
Mm-hmm.
I think patient and public, and it's not as if certain people are patients and certain people are public. As I said, people have different identities. And I think this is it's an area where I think needs some rethinking. And I think the COVID crisis has made this strikingly clear.
Yeah, like one of the ways that sometimes people talk about community engagement, or maybe better term here is public engagement, is to use social media as a way to engage the public.
Yes.
What do you think of that, and how does it go?
Well, I think that it certainly has proven to be sometimes a very useful tool. I know it's been very helpful sometimes in recruiting people, and social media often has a kind of an immediacy to it. So I've talked to many people who say that, a certain, tweet, and there are people who are very good at amplifying tweets, or something that's used on Facebook, and some snowballing effect has been very good at reaching a lot of people, at getting a lot of responses. I think all of that, that's something to recognize and to use very well. And I think we should use that. On the other hand, I think people who live within a social media world a lot sometimes have a difficulty recognizing that there are all kinds of people who don't live on this world. So there was a project in Toronto called the Clean Meds Project, and it was a project that a family physician at one of the downtown hospitals launched to look at, pharmacare, essentially. What happens if you provide medicines, essential, free of charge to people? And it was really trying to address this problem that we know a lot of people cannot afford basic medicines. So he gathered a community council, and in order to form this council, and he wanted people from a variety of backgrounds, he actually literally went around strolls. He took a walk with some friends through a community on a Saturday when a lot of people would be out, and they all wore T-shirts saying, "Do you want free drugs?" And that was one way of getting people. And it's also knowing who in the community can identify their peers who might be interested. They also did some calling. I mean, there's different people use the phone. They never use the social media, perhaps. And I think you have to think about social media as a sole strategy, and sometimes even as your prime strategy may not be the best idea. The other difficulty I think sometimes with social media is that, and we all know this, whether the topic is politics or who's your favorite author or whatever else, that sometimes there can be a lot of echoing, a lot of people agreeing with one another. This is true. I look at my Facebook page, and I see a lot of echoing of my own views on certain topics, and that's a problem. And I think I can think of one instance recently, not too long ago, when someone posted and we began talking about patient engagement, and the reality of it is, for different reasons, that term, a lot of people are thinking, the term is no longer so useful, or it's acquired some less than positive associations that they think about. So somebody was saying, I've sort of had it with patient engagement, and I understand that. I mean, I think sometimes patient engagement seems like something, initiated by institutions or organizations, and patients are often the objects of the engagement. And I know a lot of people say, I'd like to initiate some engagement. But in this case, somebody said, I've had it with patient engagement. Can anyone out there think of one good thing that's come as a result of patient engagement? And then I just noticed, and the person about an hour or two later, said, I'm hearing crickets. That is, nobody can think of a single thing. Now, it may be that not many people were on Twitter at that little period of time. But then I thought to myself, actually, I can think of all kinds of benefits, at one instance at Sick Kids where I was, where you could call it patient engagement, resulted in, improved discharge summary forms, more inclusion of patients in rounds, the use of whiteboards in patient rooms, some better signage. Now, these may not have been earth-shattering improvements, but there were tangible things that resulted from engaging with patients and families. But what I thought was, and so I wrote that, I said, well, here are some things that I'm familiar with, but I think sometimes it's, people, I think there needs to be a greater willingness to disagree sometimes, or to present a different view. And I'm not sure social media facilitates that very much, or at least the way we use social media sometimes produces a lot of, nodding, and not enough sort of reflective thought. I mean, I don't want to have a fight about it, but the question was, has anything good ever come out of patient engagement? The answer is not, and my answer was, I can think of some things.
Yeah, no, social media is almost like you put a magnifying glass on human patterns of social networks and make it 20 times as good or bad, almost.
Right. Yeah. Yes, and that can happen sometimes. And we all have seen the results of that, and I'm wondering if we can remedy that in some ways. It doesn't mean throw out social media. I can see all kinds of benefits. I learn all kinds of things from social media. I see reference to things I want to look up and find out more about, and I find out, an event that's of interest, all kinds of things. But I do think we have to recognize there are some lots of problems with it, and I think it can also be kind of exhausting.
Yeah, that's definitely true.
Yeah.
So one of the things that one of the main things that we do at the Alberta Patient Engagement Platform is give advice to primarily researchers, I would say. So if there was a researcher who was going to involve patients in their projects for the first time, is there any advice that you would give them?
Well, I think maybe a few pieces of advice. One is to ask yourself honestly, why am I doing this? We are all familiar with projects where a patient is brought on board because a patient has to be brought on board in order to qualify. So, but I think it's important, when we all recognize that's not a very good reason, if that is the reason. But there's some other things too. Someone once invited me onto a project and said, your job here is to keep us honest. And I thought, that's an awfully big task.
Yeah.
I'm the person here to kind of, tell people when they're not being honest or they're not being real or something. So I think it's important, to really ask that question, like why, and there could be more than one reason. What are we actually looking for? What are the purposes here? And to be as specific and as candid as one can be, because the patient will figure out sooner or later, and probably sooner, um, the reasons he or she has been invited onto the team. So that's one thing. I think it's important also to think about, to be willing to figure out what different things the patient can contribute, and not just to stop at the most obvious one. So you might think this patient can be very helpful to us in recruiting research subjects or participants, and that may in fact be true, and that may be an important thing the patient can do. But are there other things? So, for example, one of the things we're looking at is the analysis of findings or data. And this is something, maybe the patient needs some training on this, but patients often see things when they look at the transcripts of interviews, when they look at even, survey results.
Mm-hmm.
And they can sometimes see why why many people answered it in the way they did. And even certainly in the design of interviews, I once worked with another patient partner from Alberta, actually, Joanne Ganton, and we looked at some surveys that were being used, and we had some very specific questions about, in what order should these surveys be sent or be addressed, mm-hmm. or be completed. Even something like where the surveys are being sent. So the initial idea from the researchers was to send these surveys into families' homes have them fill it out at home. And some of the questions were quite intrusive, and there were questions about family experiences. And then the question needs to be raised, well, this actually is sort of importing into the family's, living room or their den or whatever, a whole series of questions that could be unsettling, disturbing. Mm-hmm. Are there certain questions that are best asked, in a different setting? With what preparation, with whom, who should be present at this? So, and there were also lots of questions that, we're going to get good answers only if the person responding to the questions or to the survey understood, why is this being asked? And what will happen to the results? So many of us have the experience of responding to surveys or questionnaires and being really irritated by a question we think is irrelevant, or annoying, or just unclear. So so we may check off one box or another, but we'll do so hurriedly and in a spirit of irritation. It may not be very good feedback. So maybe what the people doing this, filling out the questionnaires, responding to the surveys need is a lot more, a better introduction, a better explanation, something. And I think patients can help in the design of these, maybe not in the actual questions, or maybe they can be, but certainly in the apparatus that is provided. And I think the result will be better responses. Something else I'd suggest to researchers is that, if in doubt about how often to communicate, choose to communicate often. Mm-hmm. So that if in the course of seeking REB approval, or at a certain phase of data gathering, patients are not involved for a couple of months. Let's say your patient partners are not involved in a couple of months. That may not seem like very long to the researchers, but to many patients, it can seem like they're being left out of the loop. Mm-hmm. So even if you don't have much to communicate, communicate what you do have to communicate, or at least communicate, where we are, what we're doing, and when we anticipate, the next stage unfolding. So I think those are some things to remember.
What about the flip side then? What if there's a community member listening to this episode? What advice would you give them if they wanted to get involved for the first time?
Well, I think one thing I've heard a lot of from patients when they're asked, whether it's in a research context or whether it's in a project related to quality improvement or, you know, providing some advice about, the health system, they'll say something like, well, I'm doing this because I want to give back. Very common response. And I think that's a true response. But I think patients should also think about, okay, beyond that, is there another reason that I would like to participate? And I think, though, they might find out, well, there's a particular problem I would like to help solve, or there's a particular skill I have or interest I have that, or experience that I have, that I think I can contribute and make a difference there. So I think reflecting quite a bit um, on the many reasons, perhaps, that and the many contributions that you can make would be important, and not just stopping at this. What I think is often the first thing that people say is, well, I want to give back to the institution or this group of clinician researchers or whatever. I also think patients should, if they get involved in research in particular, be aware that this is a situation different from a clinical setting. In a clinical setting, very often, you're asked what your preference is, or to talk about your experience of an illness. And this is not a field where where people are disagreeing. You're sharing that, and clinicians in general are very good at listening to what the patient says. And if the patient says something that's not clear, the clinician's probably not going to say, "I don't understand." That's whatever. The clinician might ask another question to elicit the information. In research, however, it's somewhat different. You're a member of a team, and there could be something about which there's genuine disagreement, and that's okay. So, you might want, a certain outcome to be included, or you might think that a secondary outcome should be the real primary outcome, or you think that something else should be measured, or that you think, something, where there's some disagreement. And I think respectful disagreement, and I think the key term there is respectful, is something everybody has to develop a tolerance for and an ability to work with. I think sometimes, patients have gone in, and maybe this is the problem with researchers, who say, "This is terrific, you're wonderful, this is going to make such a difference," etc. And then the patient will make a suggestion, and then there's silence, or there's something said that is perceived as being dismissive. And I think everybody has to learn how to work through differences, to work through different perspectives, to work through disagreement sometimes, and that's something which I think is new to everyone. This new situation where we have. I mean, nobody. If you are a research subject, and you're giving samples of something, blood, or you're giving some other body sample, or you're responding to questions or something, clearly, you're not being asked to state your views or your opinions or your preferences, whatever. Or if you are stating your preferences, they're simply being recorded. But in research, you're in a different role. And I do think that there's sometimes a real challenge to people in having patience, and it's a challenge to patients as well, in being equal members of the team. And that implies everybody is invited to share their opinions and to respond to one another. honestly.
Yeah, no, I mean it's a challenge for all types of teams, but I think it's really
Yeah,
important to deal with.
And I think the question there, and it does raise the question of, whether you are an equal member of the team. So, I mean, one of the saddest things I've heard is when patients report that they've gone to a couple of team meetings, they've sat around a table, they've been given a snack or whatever, but they've come away from that meeting not really sure why they were there, why they were asked to be there.
Mm-hmm.
And that, I think, is, I mean, it dismays me, disheartens me, because, after you've been to one meeting even, but certainly after two, it should be very clear, what it is, what your role is, your role at the present, what your role might become, what you're contributing, what you can contribute. All that has to be made explicit.
Thanks so much for joining us on the podcast today.
You're welcome. I enjoyed it myself. Thank you.
Thanks so much for joining us for this episode of PEP Talks, the Patient Engagement Podcast. Brought to you by the Alberta Strategy for Patient-Oriented Research Patient Engagement Team. Special thanks to Paul Ferry, Sadia Ahmed, and Sandra Zielinski, and our summer students Sarah, Sydney, and Stella for their co-production. Make sure to subscribe to this podcast wherever you found it, and we hope you'll join us again for more interesting discussions about patient engagement in health research and healthcare.